The most important challenge right now is that for sure we are undertreating patients with peripheral arterial disease because we are not diagnosing them. We are not seeing them at an accurate time point. And so the issue is that because we are not diagnosing them at the right time, a lot of them are losing their legs. That's the first thing. The second thing is that we still do not know how to treat them. We have the guidelines that we should only treat patients with peripheral arterial disease and lifestyle claudications for endovascular. There is an issue, should we go more for endovascular or more for open surgery? And what should we do with patients with critical limb ischemia, which is an increasing portion of patients with BAT? Concerning risk factor management, we only have risk factor management extrapolated from other vessel areas, so from the coronary. We do not have specific trials for giving us the insight on how to treat our patients in a proper way. And then there's a challenge with antithrombotic therapy, so we only had aspirin for a very long time, and that was it. So at time now, if a patient has a symptomatic peripheral arterial disease, we put the patient on antithrombotic therapy. We prefer clopidogrel over aspirin. This is what was written in the new guidelines from the ESC 2017, because we have one study, one trial showing that there is an advantage for these patients, especially for patients with BAT and diabetes. Coming to revasc, we are doing revasc procedures, mainly endovascular during these days, in patients with lifestyle-limiting claudication and patients with critical limb ischemia. Still, we are not at the end with our treatment options. We still are looking for better treatment options, either medical or for revasc procedures. The treatment goal is just to prevent major adverse limb events, meaning restenosis, reocclusion, progression of atherosclerotic disease in the lower limbs. But, and that's the other thing, also to prevent other cardiovascular events, because we know that this patient cohort is in an extreme risk for having cardiovascular events, either stroke events or myocardial infarction. So this is a patient cohort which has a very high risk for cardiovascular events, and the treatment goal must be to prevent these cardiovascular events. Thanks God, there have been approaches to evaluate other antiplatelet therapies. For example, in the UK trial, ticagrelor for the treatment of patients with PAT. Unfortunately, this trial was not proving any superiority of ticagrelor over clopidogrel in patients with PAT. And the novel oral anticoagulants like rivaroxaban have been evaluated for this patient cohort. And I think that's very important because a lot of these patients also develop AFib on the side, so we always have the question how we could treat these patients who need oral anticoagulants and have PAD, and therefore these trials are very helpful. So far, as we have mentioned, we have the COMPASS trial, which has shown the value of rivaroxaban in patients with PAT. And there is another trial going on with this agent, which is the Voyager trial, where we are specifically looking what can novel oral anticoagulants do, or how is the benefit of these drugs in patients with PAD who undergo revasc procedures, either open or endovascular procedures. So this is ongoing, and I think it should be encouraged that other trials in this field are being performed in the future. That would be very helpful for us as physicians treating patients with PAD.